So on the same topic, I'll try not to belabor the same points. Let's see if I can get this to work. So reasons for pursuing interbody fusion is, as already been discussed, you get indirect neural decompression, you can restore low doses, correct deformity. And in comparing this to posterolateral fusion, there's better rates of fusion and lower complications. We've already seen this diagram, and I think this is important because when I did my training, you basically approach the spine from the front or the back. We now have a lot of different approaches, and I think because they all have different pros and cons, you can utilize this to your advantage and to the patient's advantage in different scenarios. So the T-lift was already touched on that Harms described in 82, but there's different pros and cons to this. You can't restore lower doses as well as anterior surgery. And you do affect the posterior musculature, albeit less in a Wiltz or an MIS approach than a midline. But there's also contraindications like scarring or conjoined nerve roots. This is a 75-year-old female who presented to me 2 years status post L4-5 T-lift by another surgeon, and she did okay but not great. And if you look at her preoperative MRI on the left, you can see that really this was 3-level disease that was a valiant attempt to try and treat the worst level, but she didn't do that well. If you look at the axials on the right, L3-4 and L2-3 are still quite stenotic. So this was someone I felt needed a direct decompression to go on up, and since she was already familiar with the approach, decided just to do T-lift with the other 2 levels higher, and she did well. The X-lift, which was described more recently, has its own set of pros and cons. We touched on you can't go in 5-1 because of the pelvis. 4-5 certainly has its own vascular and neurologic risks because of anatomy. And as a standalone procedure, it's been shown that if it's adjacent to a prior fusion or multi-level, it doesn't tend to do well. One of the challenges practicing in Southern California is not just the economics that were touched on today, but also patient-driven expectations for, I want a small incision, I want to go home outpatient. And you have to really ask yourself with all these different approaches, can you safely and effectively accommodate these patients? So this is a 52-year-old who came to me, 5 years status post-laminectomy from another surgeon with worsening back pain, leg pain, and after injections and the dermatomal pattern of his radicular complaints, I felt fairly confident that L3-4 was the offending level. And so to do something like a direct lateral with a plate enabled me to send him home the same day, and he did well. Here's a 55-year-old chiropractor with a large extruded disc herniation that I treated with a lumbar microdiscectomy who did well for 2 years, but then came back with recurrent leg pain. And you can see his canal's wide open. He's not stenotic, but on his x-rays he has progressive up-down foraminal stenosis, and obviously a repeat decompression would not serve him well. So again, thinking about what can I do that adequately treats him but keeps the surgery relatively small, I did a direct lateral with a posterior clamp. And of course, percutaneous screws and other things could still keep this small, and he went home the same day. When we talk about A-lift, which was described many decades ago, and it has its, again, pros and cons, if you have an adequate vascular surgeon, I think this is also something that could be considered mini-open or relatively minimally invasive, and as long as you have proper indications, this is not particularly a large approach. This is a 45-year-old who presented to me with primarily back pain, sitting intolerance, and although he has an extruded disc fragment, I really didn't think that a simple decompression would serve him well. So we talked about doing an anterior-only procedure, and this is what was done. I think the plate is overkill, but if you're below the bifurcation, it's one of the options. You can really treat this just like you would an ACDF. We're all used to peeling extruded disc out of the canal in the cervical spine, and this is really analogous to that. This is I don't like plating at 4-5 or 3-4 because of the prominence and the vasculature, but I believe if you're at 5-1, why do you plate your ACDFs? Yeah, I think it was a contest with my fellow. He asked how many screws we could put at one level. And I think the vascular surgeon's comment was after I put 7 screws, it was only because there wasn't an 8th hole. So a little orthopedic humor. But you don't have to, obviously. I think this case I'm showing here, though, slightly different because it's 4-5 and not 5-1. And this is a female with some osteopenia. I wouldn't feel as comfortable with just an anterior. I wouldn't put a plate because it's 4-5 near the vessels, and so I think PERSC screws or something from the back is what I do here. And that's what I chose to do. Here's a case, 75-year-old me, 20 years, status post L4 to S1 laminectomy and an anterior and posterior fusion. And he told me he really liked his surgeon, but he had to come to me because he now was busy and only took good insurance, and I was in his payer mix, and apparently this person wasn't. And I thought if he did this 20 years ago, he must be a really old guy, but it turns out this was Jeff Decky. So this made me feel bad for about 3 reasons. One was I was obviously lower on the economic insurance totem pole. Another was that I know we're the same age, and so I must be getting really old also. And then finally, when the patient presented to me and said, "Can't you do something way better than what was done 20 years ago?" I really scratched my head and said, "I don't know, maybe not really." Because he has 2-level stenosis above. I think he needs a 2-level decompression infusion. But the pain docs at our surgery center put in batteries for spinal cord stimulators through 2.5-inch incisions outpatient all the time. So the question is, if I can keep an incision at 2.5 inches, can I address this, minimally invasive, outpatient? Maybe, based on the principles we've talked about. So I decided if I can give him a direct lateral 2-level fusion and posteriorly still decompress him directly, maybe something like this would work. So he went home the same day, and 9 months later has done well, hasn't fallen apart. So thank you.